Thank you. Thank you so much, and thank you for accommodating me a little bit early. Good afternoon, and I was enjoying your conference, so thank you for inviting me too. So, stroke has been my personal interest for a long time, and I want to just start with these four things to say that what is the brief overview of the protected TAVR study. What are the data that are not typically covered in the stroke prevention trials? I would put some data in context with other things, and then personal clinical recommendations. So this is the idea. So protected TAVRs trial is the trial that we generated. This is published in New England Journal last year. It is to study mainly to understand that what is the clinical stroke rate in transfemoral TAVR is reduced by the CEP protection device or not. And it was a prospective randomized trial. We enrolled 3,000 patients, and in the 3,000 patients, 1,500 were with the TAVR alone and 1,500 with the CEP. And the idea was to find the stroke at 72 hours or at discharge. And we also graded the stroke as disabling or non-disabling based on the modified ranking score. Primary endpoint was that. And if you look at the data, typical 80-year-old patients for TAVR, 1/3 were extreme risk, 1/3 was intermediate, and 1/3 were low risk. Women was a little bit more in the CEP group, just by chance. But if you look at the balloon expandable and self-expanding valves, they are 60 and 30% in each. The primary endpoint of the trial was negative, to say that the stroke rate was 2.9% in the control group versus 2.3 in the device group. And in the control versus device, the major stroke or the disabling stroke was 1.3 versus 0.5. So this was statistically significant, but the overall stroke rate was not statistically significantly different. If you look at the mechanism of disabling stroke, most of them were ischemic stroke. That's what you would understand, and that made sense, that 17 versus 6 ischemic strokes. And if you look at all the strokes in detail to say that which are the strokes that happened with the CEP to try to understand that why it didn't work, it is very clear that why it didn't work was because either they were hemorrhagic or these were massive complications that happened in those patients, like embolized valves, CPR, things like that. Only one patient where we could say that the ischemic stroke could have been potentially prevented, but we could not understand why it happened. So if you look at the all stroke versus disabling stroke, it is very important to recognize that in the patients outside of United States, there was no difference. But as you see in the bottom, inside of United States, there were patients who did, who did better with stroke prevention. So this particular subgroup was positive, 1,800 patients in this group. So what are the data not covered? So this is the outside versus in the United States. So as you see, the stroke rate was a little bit higher outside, 3.5% versus 2% in United States. And if you look at the after the stroke rate was not that different, the disabling strokes. But if you look at the 72-hour stroke by arm outside of United States, there was no difference between control and CEP group, 3.3 versus 3.7. But if you look at in United States, the difference was significant. So 2.6 versus 1.3 and 1.5 versus 0.4. So this just tells us that there may be some patients that benefit from the emboli protection devices. And if you look at this, this is again to say that the mortality after stroke was less, the discharge to home was more with the CEP, all suggestive that the strokes were less disabling when you use the CEP device. If you look at the United States registry, it is also very clear that in United States registry, the NRD registry, if you look at the stroke death, the death after stroke was 6.3% versus 11.8% if you use CEP or you did not use CEP. So again, very important information to keep in mind. And if you look at the TVT registry, it was 1.4 versus 2.2%. Cleveland Clinic experience, if you look at our own experience, we have 3,000 patients, 1,000 patients treated with CEP and 1,800 patients that were treated with CEPs, 1,000 without CEP, 15 strokes in the patients without CEP, 8 with CEP. But very importantly, the stroke were less severe in the patients who were treated with CEP, and 4 patients died out of 15 who had stroke without CEP. Nobody died after the CEP and stroke. So they were all minor strokes. So the risk of mortality after stroke is reduced in patients with CEP compared to those without CEP. So what are the things that we do? So this is our own data. This is the typical device that we use. Is the Sentinel device. That's the only device that is currently approved in United States. So this is the CEP device. When we use the device, this is our data for last 5 years, 3,000 patients. We have 2023 data, look very similar. 0.4% mortality, stroke is 0.5%. More than 2 plus AR is 0.4%, and new pacemaker rate is 2.9%. So again, using the CEP device, we have been able to reduce the stroke to less than 1% in all patients, almost 4,000 patients now if you include 2023 data. What is happening in the landscape? So the landscape is changing in the sense that Sentinel is a first generation device. There are several newer devices that are being tested right now. They are all either deflecting devices or capture devices with the different pore sizes. Most of them are from femoral access, except for the Protumbo, which is the left radial access. And as you can see, the access site size also varies. There's another very important thing that's happening is that the BHF Protect TAVI's trial is already enrolling, and it has enrolled a large number of patients. We are expecting that by the end of the year, it should complete enrollment, and we will have some data. Their presumptions are different. We thought we will reduce from 4 to 2%. As you know, we were about 3% to 2%. So their assumptions are a little bit more realistic. So hopefully we will get better data with this particular trial. We have already said that we would like to combine the data, and we have already put that prospectively as a goal. So stroke is still a clinical problem, although the risk of stroke is getting a little bit better. The Sentinel has been shown to be associated with decrease in the disabling or major strokes. Device is safe. Stroke remains unpredictable. And we have been using Sentinel device in all patients. Again, it's a cost. So if you can afford it, it's worthwhile in my opinion. And there are several new devices that may be slightly better, again, require more data. And then there was one other question raised in the talk to say that how we manage stroke. We have been managing stroke most commonly if they're minor strokes. As I said, most of the patients are minor strokes. Then we typically do not send them to neurointervention. But if they're major strokes or major artery occlusion, then neurointervention is necessary. Everybody should have a CT scan prior to sending them to the neurointervention, because some of them may have a hemorrhage. Very rare again these days, but this is something to keep in mind. So thank you for your attention.
Thank you very much, Professor Kapadia.
Thank you very much. I would like to make a question, please. Thank you for your speech, but I'm wondering if that stroke happens, it's something that we can do differently from the other strokes. I mean, if we have to manage this type of stroke, we have to make something different from the other type of stroke that we manage in other operations.
So since the TAVR is done with conscious sedation, first of all, the recognition of the stroke happens immediately after the procedure, right? So that the time from the stroke to the time of management is fast. So what everybody recommends is to take the patient from the cath lab or hybrid room first to the CAT scanner and make sure that there is no hemorrhage. If there is no hemorrhage, CT angio from the brain is necessary. And if you do the CT angio and if you either find a calcified embolic material or a major artery occlusion, then take the patient to the IR suite and try to retrieve the calcium. If you do not find either of this, so if there is no calcific material or there is no major artery occlusion, then conservative management is reasonable. So this has been the typical workflow for these patients, a little bit different than, let's say, open heart surgery or something like that, because by the time people are extubated or this thing, there is some time that has elapsed. So doing a neurointervention is less effective in those patients. But these days, with the embolic protection devices, in last 7 years, we have not taken anybody to neurointervention because these large strokes are not seen.
Thank you very much.
Is there anyone for a suggestion, a comment? Well, do you agree with the common belief among... do we have... It's gone? Is Dr. Kapadia with us?
I am here, I'm here.
Oh, okay, thank you. Well, do you agree with the common belief among structuralists that all patients, especially those who calcified valves, should be treated with a protecting device? And if yes, is there enough evidence, published evidence, to support it?
As I said, that yes, in my opinion, if you can afford it, you should try to use it because the device is safe, and if it does capture embolic material. The published data are not enough to say that this is a class 1 recommendation. So there is no, because the randomized trial, the protected tower trial that I did was negative. But on the other hand, the BHF TAVI trial is ongoing. By the end of the year, we should have 10,000 patient data from a randomized trial. So very soon you will have an evidence-based data, but at least in United States registries, TVT registry, national registry, it looks like that there is benefit. Currently, I would say that if you are doing bicuspid aortic valve or TAVR valve-in-valve, these are the patients that you definitely should use emboli protection device. And the rest, it is a little bit of we will need more data.
Thank you. If Dr. Tsikaderis or Dr. Iakovou want to make something, you can proceed. Thank you, Professor Kapadia.
Thank you. My pleasure. Thank you.
Yes. Thank you very much.